That's the one.
Hmm.
So basically what happens is you get exposed to the virus, and as we'll see, this is a highly contagious virus.
Hmm.
You then have the incubation phase that lasts about 5 days.
Hmm.
Now, this then goes into the symptomatic phase where patients have fever, malaise, cough, and whatever. This lasts about 8 days. And then, as you'll see, the virus stops replicating. And we'll come to this because you have no active viral replication. You then go into the symptomatic pulmonary phase and the late pulmonary phase. Now, the point about this is you have profound immune dysregulation. And this is not due to viral replication or viral cytopathic effect. This is such an important concept. The immune dysregulation is a result of the host response to dead virus. The viruses are dead, and the host is responding to these dead viral fragments. So that's why the distinction between the symptomatic phase, where the virus is actively replicating, then at about 8 days after symptoms, the host immune response, probably through cytotoxic T cells, the virus is dead. But patients still remain PCR positive. If we go to the previous slide number, which we were looking at, yes. So basically what this does is looks at the PCR and looks at live virus by culture. So the crosses are PCR, and it's on a log scale. So you can see that initially, the first 10 days, the PCR, the viral load is exceedingly high. We're talking about 10 to the 9, 10 to the 10 virons. So that's a billion. A billion viruses per milliliter. So there's an enormous viral load. The dark circles reflect those patients that have viral culture positive. So you will see patients only have positive virus culture up until day 8. Past day 8, all the viruses are dead. What you're picking up on the PCR is you're picking up dead viruses. You're picking up RNA fragments. So the fact that the PCR is positive does not mean the patients have living, replicating virus. What you're picking up is RNA fragments from all the gazillion dead viruses. So this becomes really important because if you think about it, giving an antiviral drug when you have dead virus doesn't make sense because once the virus is dead, it's dead. You can't kill something that's dead. And it's kind of reproducible. This is days of symptoms. You know, you have from symptom onset, you have fever for about 12 days. You then have cough for about 18 days. But you can see the shortness of breath begins at gate 7 or 8. And that's when the viruses stop replicating. It's important to distinguish these two phases, the viral replication, and then the virus is stopped. All you have is these trillions of pieces of viral debris. It's the viral debris phase in which you get this profound immune dysregulation. And I think that distinction is so important to appreciate. So using remdesivir at this phase or monoclonal antibodies or convalescent serum just doesn't make sense. And, you know, you listen to the experts speak and they never talk about this. It's in the inflammatory response. So what you want to do is you want to start treatment early when the patient starts developing pulmonary signs. It's not rocket science, actually. So that's why, you know, you monitoring the O2 sats is so important. And once patients start developing pulmonary signs, it means they're getting into the severe inflammatory phase, and you have to quell the inflammation. It's like a fire. And the longer you wait to put the fire out, the more destruction the fire has caused and the more difficult to put out the fire.
Hmm. Hmm. Makes sense.
Let's go to the next slide, which again shows it again. So this is really, again, important because, people get a PCR and they think that this is active viral replication. So this slide again shows you that the PCR likely is positive for 3 weeks, but the virus has stopped replicating. The other thing that is really important, which people don't recognize, is the false negatives. So if you have a look at the peak, which is on about, again, it's on about day 8 after exposure, only about 80% of people with COVID will be PCR positive. 80%. So we have many patients who have all the features of COVID, and you can test them 6 or 7 times, they remain PCR negative. So COVID is essentially a clinical diagnosis. The PCR is there to help support you, but a negative PCR does not exclude COVID. It's such an important point.
That's a very important thing.
And if you think about it, 20% of people who are negative actually have COVID. And then you can see that the antibody response kind of kicks in once the viruses stop replicating, obviously indicating that the development of cell-mediated immunity from B cells and T cells. So this follows the end of viral replication.
Got it.
People are pushing dexamethasone. We much prefer methylprednisolone. So this is a summary of studies using dexamethasone, methylprednisolone, and hydrocortisone. And you can see that the number needed to treat is much less with methylprednisolone than with dexamethasone. So I think this slide shows that clearly. So we strongly recommend